السلام عليكم.
وعليكم السلام ورحمة الله. هذا دكتور مشهور.
دكتور بديب, if you are ready, can we start?
Okay. Thank you very much. Assalamu alaikum. Good evening everyone. Today I will present gastrointestinal bleeding, specifically the lower gastrointestinal bleeding. So the outlines for my lecture will be some introduction and background for lower GIT bleeding. We will discuss some guidelines on the resuscitation and diagnostic modality and treatment option for lower GIT bleeding. I hope my voice is clear for everyone here. So lower GIT bleeding, by definition, is any blood loss or any pathology that is proximal to the ligament of Therese result in a blood loss. This lower GIT bleeding is suspected usually when the patient complains of hematochezia. Hematochezia means passage of marron or bright red blood or blood clot per rectum. Lower gastrointestinal bleeding is less common than the upper GIT bleeding, and it represents about 20 to 33% of the total gastrointestinal hemorrhage. The interesting fact about the lower gastrointestinal bleeding is that it can resolve completely spontaneously without any surgical intervention, only with aggressive supportive care in 75 to 85% of the patient. Now, in regard to the mortality, as we mentioned in the previous lecture about the upper GIT bleeding, the overall mortality in lower GIT bleeding is much less than the upper GIT bleeding. Only 2 to 3% of the patient will develop have a risk of mortality. Nevertheless, this related to other comorbidities that the patient may suffer of. Most of the cases of lower GIT bleeding will be treated with non-urgent evaluation. Nevertheless, if the patient have a severe hematochezia, then urgent diagnosis and urgent intervention is required to control the bleeding. By definition, severe hematochezia means any continuous bleeding within the first 24 hours of hospitalization, any drop of hemoglobin at least 2 grams per deciliter, and or transfusion requirement of at least 2 units of packed RBC. So in regard to the etiologies of lower gastrointestinal bleeding, this is a very interesting classification. It was obtained from UpToDate. It can be classified as an anatomic example for that is diverticulosis. We have vascular causes as angiodysplasia. We have hemorrhoids, ischemic causes, and post-biopsy or bulopectomy, radiation-induced telangiectasia, inflammatory causes, and neoplastic causes. By far, diverticulosis is the most common cause for lower GIT bleeding, represent about 30% of the total case. This is followed by anorectal disease, represent about 14 to 20%. Nevertheless, we have to appreciate that anorectal disease in patients who are less than 50 years old can be considered as the most common cause for rectal bleeding. However, the hemorrhoidal bleeding is usually minor, thus it can be differentiated from the other causes of lower GIT bleeding. This followed by ischemia, inflammatory bowel disease, neoplasia, and arteriovenous malformation. The evaluation of the patient start by taking a thorough history and physical examination, and there is very important point that we should to appreciate before proceeding into any further laboratory investigation or imaging modality. First of all, we have to check for any prior episode of GIT bleeding, any past medical history, including any comorbidities, medication use. In particular, we mean the non-steroidal anti-inflammatory drugs, antiplatelet agent, and anticoagulant agents. We have to appreciate if the patient have any history of radiation or chemotherapy. We have to ask about any symptoms that may suggest a particular etiology that help us to reach the diagnosis. For example, we have painless hematochezia with diverticular bleeding. We have sometimes change in bowel habits with malignancy. We have abdominal pain with colitis. So what are associated symptoms are important to look for, and how do they help how they do help in the differential diagnosis? Well, for example, when we have systemic symptoms as fever, bloody diarrhea, these may indicate infectious or inflammatory causes. Recurrent symptoms in younger patients can raise suspicions for inflammatory bowel disease. Weight loss can raise suspicion for malignancy. The presence of straining can suggest an anorectal causes. If this is painless, this can suggest an internal hemorrhoid. If it is painful, this suggests anal fissure or external hemorrhoid or thrombotic hemorrhoids. Tenesmus can present in which mean a sense of incomplete evacuation of stool can be seen in cases of ulcerative colitis, infectious etiologies, including proctitis. Bleeding from diverticulosis and angiodysplasia actually is painless. The abdominal pain, especially in elderly patients, should raise suspicion for ischemic colitis, particularly in setting of low flow state. So here is very important thing that we should to understand, that the lower GIT bleeding from the right side of colon can manifest as a Maron stool. And the left-sided bleeding source may be evidenced by bright blood per rectum. However, in practice, patients with upper GIT bleeding and also those with right-sided colonic bleeding may also present with bright red blood if the bleeding amount is massive and brisk. Cecal bleeding may present with melena, which typically seen in upper GIT bleeding. And that will be present if the blood took a long time in the colon. Thus, the color of the blood will change from the bright one to the dark one. That means that the clinical evaluation only, it's not sufficient alone to determine the source of bleeding. Also, in physical examination, we have to assess the hemodynamic stability of any patient. We have to do a BR examination to confirm the presence of hematochezia or melena. We have to check for abdominal tenderness. Well, for example, there's the usual secret word in the board exams, like pain out of proportion to examination, which can suggestive of mesenteric ischemia. Also, the abdominal tenderness can be suggestive for colitis, as an inflammatory bowel disease, ischemic colitis, or infectious diarrhea. Abdominal tenderness usually unusual in cases of diverticulosis and angiodysplasia. This table demonstrates the different etiologies and the typical presentation. We will not go into all of them. However, during the upcoming slide, we will cover some of these causes. As we mentioned before, that the upper GIT bleeding, the lower GIT bleeding sometimes can present as a cause of melena, and the upper gastrointestinal bleeding also can present as a hematochezia. Therefore, we have to exclude the upper gastrointestinal bleeding in any case of lower GIT bleeding. Therefore, an insertion or placement of nasogastric tube is necessary. So after all the resuscitation effort, we have to place a nasogastric tube to detect or to locate the presence to exclude, the upper GIT bleeding. Also, we have to do a careful digital rectal examination, anoscopy, or proctoscopy to exclude anorectal sources of bleeding. As this presentation actually was apart from the previous presentation, which was about the upper GIT bleeding, therefore, for time limitation, we will not repeat every single thing in regard to the initial management. However, the treatment goal can be summarized in three main things or three main outlines. First of all, is resuscitation and initial assessment. Then we have to localize the site of bleeding. Then we have to do the therapeutic intervention to stop the bleeding at its site. So in resuscitation and initial assessment, we have to assess any signs of hemodynamic instability and postural change, for example, with dyspnea, tachypnea, and tachycardia. Also, we have to establish a large bore IV cannula and provide fluid resuscitation, as we mentioned before, in regard to the shock stage. In the stage 1 or 2, we have to replace with corticosteroid and roll of 3-to-1. I mean 3 IV fluid for each hemoglobin to be raised. And in the stage 3 or 4 of shock, we have to replace with blood product. We have to order the basic routine laboratory studies, CBC, electrolyte, and coagulation profile. And the most important thing is these should be used as a baseline assessment and to check if there is any drop in the patient hemoglobin. Also, blood should be type and cross-match. And the reason for that, if there's any surgical intervention or any massive blood transfusion is going to be. We have to, the hemoglobin should be maintained above 7 grams per deciliter. And so once there is a drop of below 7 grams per deciliter, and the bucket RBC transfusion would be necessary. Also, the hematocrit, we have a target for hematocrit to be between 20 to 25 in young patient and to be about 30 in high risk older patient. In regard to, sorry, I did not go into detail about the resuscitation because we addressed this thing in the previous lecture. So the localization of bleeding site. We have to understand that in about 10% of patients present with lower GIT bleeding, they have actually upper GIT bleeding. So as we mentioned before, nasogastric tube should be inserted in any patient with lower GIT bleeding. Also, if there is a high suspicion, then endoscope or esophagogastroduodenoscopy should be performed. So what are the modalities that we have to localize the bleeding site? This is the most commonly used, or the most reference are notes. You will be notes in any medical reference. Usually we have colonoscopy, angiography, CT angio, and radionuclide imaging. So usually I will talk about the approach and how we choose which of this modality. However, I will do now just explanation and talk about each advantage and disadvantage of each modality. I will start with colonoscopy. Colonoscopy actually provide a precise diagnosis and localization, and actually it has some therapeutic value. Endoscopic therapy can be possible for the colonoscopy. However, it needs colon preparation, and sometimes if there is there is risk for sedation. So sometimes there is the patient, if the patient cannot tolerate the colonoscopy, or the patient is hemodynamically unstable, colonoscopy is useless and cannot be used in that moment. Then we have angiography. It accurate localized bleeding score, and it does not require any bowel preparation. Nevertheless, it should be used in patients with active bleeding. If a patient has no active bleeding, the angiography is useless. And actually, there is some complication that may arise from the angiography, including contrast induced nephropathy, and there is a risk for bowel ischemia in about 1 to 4% of the patient. Then we have we have CT angiography. It's non-invasive. It provides anatomical detail, and it's widely available. However, it has the same contrast-induced nephropathy risk as angiography. Also has no therapeutic value when it's used. Finally, we have the radionuclide imaging, include target RBC scanning. It's non-invasive. It's very sensitive for low rate of bleeding, include 0.1 milli per hour, can be detected by radionuclide imaging. However, it's not therapeutic. It does not localize the site of bleeding. It's only tell if there is bleeding or no bleeding, and it's not widely available in different centers in different healthcare centers. So now, what's the importance of the colonoscopy? Colonoscopy is the initial procedure for nearly all patients presented with acute lower GIT bleeding. It's diagnostic and therapeutic at the same time. One of the most important things that we should be initiated is the presence of stigmata of recent hemorrhage. This can be included in active bleeding, and the presence of non-bleeding visible vessel, and adherent clot. The value of the presence of stigmata of recent hemorrhage, that if any patient who has a stigmata of recent hemorrhage and did not go to endoscopy or therapeutic endoscopy, he has a very high risk of bleeding that can reach 60%. About the time of colonoscopy, the time of the optimal time for colonoscopy treatment was controversial. Nevertheless, most of the studies suggest that it should be done within the 24 hours of presentation, shortly after resuscitation and stabilization of the patient. So this is again discussed about the radiographic imaging. So the question again, what are the surgeons? Well, actually, the surgical intervention has been decreased also in cases of lower GIT bleeding. This is caused by the evolution and the advance in endoscopic and interventional radiological utility. Therefore, the surgical intervention was completely limited for this in this situation. If the bleeding source has been clearly identified, but the non-surgical intervention have failed, if there's a continuous bleeding, 6 or more units of blood cells transfusion, if there is lack of diagnosis despite the thorough workup using endoscopic and radiographic modalities. So if there is failure of treatment, failure of localizing the bleeding, or failure to stop the bleeding, this will indicate surgical intervention. So how to approach? The first thing to do is to classify or to determine the severity of the lower GIT bleeding. It's whether to be a massive bleeding, or can be occult, or can be moderate bleeding. Massive bleeding, it's any patient of 65 years on age and more, and with medical comorbidities, who present with hematochezia or bright red blood per rectum, and there is hemodynamic instability, including hypotension, tachycardia, low urine output, and hemoglobin level of less than 6 grams per deciliter. This actually usually most commonly due to diverticulosis or angiodysplasia, and the mortality rate is high, can reach 21%. Here we can see the moderate bleeding is a patient with at any age, present with hematochezia or melena, hemodynamically stable. He has a long list of disease, including benign anorectal, congenital or inflammatory or neoplastic disease that will result in moderate bleeding. Finally, we have occult bleeding, which patient with any age, he is can present with anemia, microcytic hypochromic anemia, usually iron deficiency anemia, and we have also a long list of diseases that can result in occult bleeding. Now, how do we approach any case of lower GIT bleeding? So we have acute chronic or acute lower GIT bleeding. The first step is to resuscitate and transfuse blood if needed. After the full effort of resuscitation and blood transfusion and stabilization of the patient, the first step is to exclude the presence of upper GIT bleeding. So to do that, we have to do a nasogastric tube nasogastric tube. Then we have to aspirate. If the nasogastric tube is positive, then we have to do gastroduodenoscopy or endoscopy, upper GIT endoscopy, to exclude any presence of upper GIT bleeding and treat in regard to it. If it was negative, then we have to exclude the anorectal bleeding, doing bronchoscopy, anoscopy, just to exclude anorectal disease. If it has been excluded, then we have to ask, is this patient present with massive threatening bleeding? Then if the answer is yes, as we mentioned, this is the criteria for massive bleeding. The most common causes are diverticulosis and vasopressin. Then the best initial step is to do mesenteric arteriography. It's diagnostic and therapeutic. So if it becomes positive, for example, for angiodysplasia, we can inject vasopressin or do embolization for angiodysplasia. And then if there is failure of this treatment, we will do surgical intervention by segmental resection. If the mesenteric arteriography is negative, then we have to explore that will be a surgical intervention. This will need an intraoperative endoscopy as well to help or to assess the diagnosis. If it is positive, then we will do segmental resection. If it is negative and the bleeding is still to be massive, then total colectomy will be needed. So what about if the bleeding stop or slow it down or become very minimal bleeding? Then we can do elective colonoscopy. If it is positive, then we will do endoscopic treatment, and if there is rebleeding, segmental resection will be advised. If it is negative, then we will have to assess the case at another time. Some textbooks suggest to do re-endoscopy to check for any further cases electively, maybe after 4 to 6 weeks, and to check if there is any cause can be treated after a few months or after a long duration of the treatment. Here we have, what about the moderate bleeding? If the patient has moderate bleeding, we have two suggestions. It's whether to do an adjunct endoscopy or to do RBC or scintigraphy or radionuclide imaging. So to choose between the both of them is depend on different factors, depend on the presence of trained staff and the presence of utility to do it. Sorry, I did not mention the study. However, adjunct endoscopy is the most commonly used. If the adjunct endoscopy is positive, then colonoscopic treatment or segmental resection will be due, as we mentioned before, for the massive bleeding. If it's negative, then we will do explore intraoperative endoscopy. If it's positive, segmental resection for the site that was detected to cause bleeding. If it is negative, total colectomy will be done. Now, the most important thing about the RBC scintigraphy is to detect the presence of bleeding or not. If it's positive, then the next step is to mesenteric arteriography, and then it will be dealt, as we mentioned before, in the case of massive bleeding. If it is negative, we will deal with it as the case of negative adjunct colonoscopy. So now, Dr. Mashur, can I present this case and ask for the resident to participate with me or not for this case?
Yes, please.
So we have this case is a 79-year-old male with aortic stenosis, came to the emergency room because of worsening of fatigue for 5 months. During this time, he had also intermittent bright red blood mixed with the stool. He has not any abdominal pain or weight loss. Physical examination show pale conjunctiva and crescendo decrescendo systolic murmur best heard at the second right intercostal space. The abdomen is soft and non-tender. Laboratory lab studies show a hemoglobin of 8 grams per deciliter. The MCV was 71. Colonoscopy show no abnormalities. Which of the following is the most likely underlying mechanism of this patient bleeding? So you can answer by chatting if you don't want to participate by the microphone. Okay, anyone that would like to participate in this question? Okay. Should I proceed to answer?
Go ahead.
Maybe D, Dr. Muhammad.
Thrombus in the superior mesenteric artery. Is there any clue in the question, doctor, for this answer or not?
I don't know. This is cardiac patient with maybe he has mesenteric ischemia causing bleeding.
Okay, thank you for the participation. Actually, the answer is A. So actually, the presence of aortic stenosis, gastrointestinal bleeding, can be suggestive of Hyde syndrome. Hyde syndrome is characterized by gastrointestinal bleeding, aortic stenosis, and acquired von Willebrand syndrome. The clue here that we have non-painless bleeding, and that's why we can exclude the superior mesenteric artery thrombosis here. So that's why the answer will be A. It's tortuous and dilated submucosal blood vessel. This is suggestive of angiodysplasia. So angiodysplasia, as we mentioned, is the most common gastrointestinal cause of bleeding in case of Hyde syndrome. Here I put an article about it. So what is the next? We have now diagnosed as angiodysplasia. What's the next step for it? We have CT angio, repeat colonoscopy, RBC target scan, angiography. Any suggestion?
Okay. What usually we are going to do, guys? Choose the usual things we are doing in our practice.
Should I proceed?
Go, Dr. Babu.
So okay.
CT angio.
Okay, so
I will do CT angio.
Okay, so this was a very controversial question. So as in this presentation, the proper answer would be angiography as a diagnostic and therapeutic. However, we cannot say that the CT angiography is a complete wrong sentence. It's depend on multifactorial thing. As a typical board question, as I quote from the writer of this question, angiography will be used. However, in clinical practice, CT angiography will be the correct answer. So for board exam will be angiography as it has diagnostic and therapeutic valuation. However, in practice, CT angiography could be the most probable or the most convenient thing to do. So we have this case also. It's very interesting case. We have a 39-year-old woman come to physician with recurrent bleeding per rectum. Examination after a colonoscopy showed 24 hamartomata polyps. The physical examination findings are shown here. Which of the following condition is most likely to develop in this patient? So we have to focus. We have recurrent bleeding, colonoscopy show multiple polyps, and the physical examination, the finding here. So we can ask before we proceed to the answer, what is the diagnosis of this case before we? It's a usual board question, I think.
This is Betz-Jeghers syndrome.
Excellent, right question. So which one of these cancers are most commonly related to Betz-Jeghers syndrome?
I think it is either malignant melanoma or pancreatic cancer.
Okay, so the correct answer is A. Pancreatic carcinoma. This is a typical presentation for Betz-Jeghers syndrome characterized by development of non-cancerous growth hematomatous polyp, and gastrointestinal in the gastrointestinal tract. There is also increased risk for developing different cancer, including pancreatic, breast cancers. So here is only some few question and answer that can make this lecture more interactive. So why the history of pelvic radiation or prior aortic surgery is very important in assessing patients with lower GIT bleeding. Should we ask about any history of pelvic radiation or prior aortic surgery in patients with lower GIT bleeding, and why?
Yes, of course.
Why?
Because of risk of anterior aortic or aortoenteric fistula.
Excellent. So for the cases aortic surgery, as we mentioned, as Dr. Sorry, I did not get your name. As Dr. mentioned, it's can result in erosion of the aortic graft leading to aortoduodenal fistula. Radiation is also very important to assess in patients as it can result in proctitis that can be acute or chronic, and there is different presentation for them. I mentioned it here in this slide. So what are the most common causes of massive chronic hemorrhage? What are the causes of what are the most common causes of massive chronic hemorrhage?
Diverticulosis is one of them.
Yes, that's correct. And the second one?
Angiodysplasia.
Angiodysplasia.
Yeah, angiodysplasia.
That's correct. And diverticulosis and angiodysplasia. So the question is, how common is a diverticular bleed? Is it common to have a patient, if you have a patient with diverticulosis, is it common to see in all patients with diverticulosis or not? Okay, I will proceed to answer. Actually, diverticular bleeding is the most common cause of lower GIT bleeding in about 30 to 50%. However, it's only occur in 3 to 5% with diverticulosis. Okay. What can cause diverticular bleeding, diverticulosis or diverticulitis?
Diverticulosis.
Correct. The significant GIT bleeding actually from diverticulosis, and the diverticulitis usually is not associated with bleeding. So now about angiodysplasia. What is angiodysplasia? What are the risk factors? Or what is the most common location for it? Does it cause massive level GRT bleeding? And what are the associations? So let's start with the first question. What is angiodysplasia?
It's arteriovenous malformation.
Mm-hmm.
Yes, it's true congenital arteriovenous malformation.
The source of bleeding, doctor, from the angiodysplasia, is it venous or arterial? Okay, so what about the risk factors of angiodysplasia? What are the risk factors? Any risk factor is known? So you can guys ask any of these questions, answer any of these questions. We just wanted to be more interactive discussion today. Okay, just for time's sake, I will proceed. So angiodysplasia, it's a focal submucosal area of thin and dilated ectatic vessel in GIT tract. It's the most common vascular anomalies in the GIT tract. The most common location is cecum. It's increased with age. It's usually linked to degeneration of the vascular wall. Typically, it results in a small quantity or occult blood. However, it can result also in large bleeding, as it's one of the most common causes of large bleeding. The diverticular bleeding usually is an arterial origin. However, angiodysplasia usually venous in origin. Therefore, the bleeding is not always massive from angiodysplasia. The association between angiodysplasia include von Willebrand disease, aortic stenosis, and chronic kidney disease. So here's another question. What are the difference between ischemic colitis and acute mesenteric ischemia? Anyone to participate, or should I proceed directly to the upcoming slide? So, okay. So, between the ischemic colitis and acute mesenteric ischemia, the pathophysiology can be different. The usual cause of ischemic colitis is hypoperfusion due to low flow state, volume depletion, heart failure, vasoconstricting drugs. However, in acute mesenteric ischemia, usually it's from embolus, from arterial embolus to superior mesenteric artery. If the patient have to decide between which etiology he would like to have, he would choose ischemic colitis. The reason for that is 80% of ischemic colitis will resolve spontaneously with supportive case only. Nevertheless, in acute mesenteric ischemia, this will lead to bowel necrosis and require resection. The diagnosis of ischemic colitis is usually done by colonoscopy. However, in acute mesenteric ischemia, CT angiography is the modality of choice. So what is the leading cause of small bowel GIT hemorrhage? Sorry for GIT. What's the leading cause of small bowel hemorrhage? The most common cause or the leading cause for small bowel hemorrhage. Any idea? Okay. So the small bowel arteriovenous malformation are the most common causes, and one of the best modality for them is target RBC or radionuclide scanning for them. Here we have the last question. What is the treatment of radiation proctitis? That we mentioned before. Usually, formalin enema is effective for controlling the bleeding of radiation proctitis. So this is the presentation for today. I just wanted to be more interactive between us, and I really waiting for your comments and your question. Thank you, everyone.
Assalamu alaikum wa rahmatullah. I mentioned it before, Dr. Badib, excellent presentation. I would say only I'm proud of you. This level of presentation reflects a very good, very excellent background, and reflecting someone who's reading a lot, and keep it up. That's just the beginning for you, but I'm sure it will be the future bright for you.
It's an honor, Doctor. Really, it's an
honor. Inshallah, I would say I know that you have interest in cardiology, but I would suggest that if you convert that to surgery, some basic surgery will be excellent for you. So thank you very much again. Open discussion with one case scenario from the real life that we have every day in the hospital. So it's a 60 years old male patient came